Hello everyone! Have you ever experienced running out of breath while exercising? That breathlessness that makes you really stop doing sports? Well, today we will try to understand ventilatory limitations to exercise. And we will do this based on a chronic condition which is also one of the most common causes of mortality worldwide: chronic obstructive pulmonary disease. So let's review what we know so far. First of all, we know that the level of physical activity is one of the most important prognostic markers we have in COPD, and we also know that those patients who are very inactive have a higher risk of mortality when compared to patients who are physically active. And the good news is that we can actually train those patients, and the higher their physical exercise capacities, the higher their physical fitness, the lower their relative risk of death. This means that patients with COPD should become less sedentary, should engage daily in high levels of physical activity, and should practice regular exercise training in order to improve their cardiorespiratory fitness. This is actually one of the main reasons why pulmonary rehabilitation works, why pulmonary rehabilitation improves health status, hospitalization rates, anxiety and depression, as well as exercise tolerance. However, COPD has an important impact on patients' quality of life, predominantly because of the main symptom of this chronic condition, which is shortness of breath, also called dyspnoea. Breathlessness is something that even athletes and healthy subjects don't like, and in COPD, dyspnoea occurs at very low to moderate exercise intensities. This is exactly what causes the so-called dyspnoea spiral, where patients start to avoid exercising, leading to physical deconditioning, to a worsening of exercise-induced dyspnoea, and therefore to an even more sedentary behavior. The spiral becomes deeper and deeper, and finally, dyspnoea will occur also during daily activities. But there is good news. We can actually stop this spiral. We can stop this spiral with specific exercise training. To ensure a safe and effective exercise training intervention, we have to understand our patients' functional limitations to exercise, and based on them, to provide them with individualized exercise prescription. There are different kinds and types of functional limitations to exercise. Some of our patients will show cardiac limitations to exercise, others peripheral or musculoskeletal limitations to exercise. However, in COPD, most of our patients will have important ventilatory limitations to exercise. There are different pathological conditions which may lead to ventilatory limitations to exercise, like, as we've discussed, COPD, but also asthma, or also patients who had surgical lung resection, pulmonary fibrosis, or COVID. Early dyspnea and reduced exercise capacity, reduced exercise tolerance are the main symptoms of these patients. However, during functional evaluations, also other different signs could be observed, like peripheral desaturation or ventilatory perfusion mismatch. This mismatch is related to ventilatory inefficiency, because either parts of the lung that are ventilated aren't perfused, or vice versa, parts are perfused but aren't ventilated. This is frequently associated with a reduced breathing reserve at peak exercise intensity, meaning that these patients have to utilize the whole ventilatory capacity during exercise. Frequently, dynamic hyperinflation also worsens the symptoms of dyspnea during exercise. Higher ventilatory demand and breathing frequency with increasing exercise intensity may lead to progressively hyperinflated lungs, which increases the work of breathing and affects the respiratory pattern. These signs and symptoms are important barriers for our patients during exercise training intervention, and patients will stop training at very low intensities, which will disallow or limit adequate training adaptations. This is why we have to provide specific exercise recommendations, assisting our patients to bypass ventilatory limitations with adapted physical activity. And this would hopefully lead to improved patients' compliance and adherence, and to increased training intensity or durations, and therefore to improved cardiovascular, metabolic, and peripheral training adaptations. But how can we bypass these ventilatory limitations? Well, it's very important to optimize pharmacological treatment of our patients, and we can propose specific types and modalities of exercise training involving smaller muscle mass. Smaller muscle mass means lower oxygen consumption, leading to reduced ventilatory demand and therefore to reduced dyspnoea during exercise. For example, to my patients, I could propose endurance training at a cycle ergometer rather than on a treadmill. This should lead to less dyspnoea at a certain regulated exercise intensity. In certain patients and in certain clinical conditions, I can also consider supplemental oxygen during exercise training in order to improve exercise tolerance for our patients. Now the question to ask is, does supplemental oxygen really work? We know that oxygen improves exercise performance and exercise tolerance by increasing oxygen saturation and by improving the breathing pattern and efficiency. And this may potentially lead to reduced work of breathing and dyspnea. Supplemental oxygen also leads to pulmonary vasodilatation, which increases the cardiac output and thereby improves peripheral blood flow. However, there are very heterogeneous study results regarding training intervention with supplemental oxygen, and current evidence concludes that on one hand, there is still little support for oxygen supplementation during exercise training interventions in COPD. But on the other hand, there are some studies which were able to reduce dyspnea during exercise training with supplemental oxygen, leading to increased training intensities, improving thereby at submaximal level patients' endurance time as well as patients' peak exercise capacity. This means that supplemental oxygen could actually be an option to bypass ventilatory limitations during pulmonary rehabilitation. However, medical evaluations are needed and we need to provide gas-specific exercise prescription in order to increase the training intensity with supplemental oxygen. We need to provide high oxygen flow rates during exercise training, which should be considered for specific goals and for specific patients in pulmonary rehabilitations, being aware that there will be also non-responders during the exercise training intervention with supplemental oxygen. It's important to better understand when and how to use supplemental oxygen during exercise training interventions in COPD and in which kind of patients. This is why we need further clinical trials to improve current evidence. But still, don't forget, exercise training remains the key intervention. So, the main take-home message is that we have to find strategies to bypass ventilatory limitations to exercise in order to facilitate training adaptations in COPD and in other lung diseases.